Hi, I'm Simon Smale. I'm a consultant gastroenterologist in York, and I thought today I'd talk about irritable bowel syndrome, and in particular the diagnosis of irritable bowel syndrome. The reason for doing that is because I'm often asked by doctors and also by patients, how can we make that diagnosis, and how can we be certain that irritable bowel syndrome, or IBS, is the right diagnosis? So, to begin with, irritable bowel syndrome has defined criteria in terms of the story that patients present with. First of all, any patient who presents with a 6-month history of abdominal pain or discomfort associated with bloating and or altered bowel habit should have that diagnosis considered. However, that's not the whole story, because clearly abdominal pain and discomfort and altered bowel habit and bloating may be features of other diseases. And so when we hear that story, we need to consider other features. So things that we should look out for that might raise alarm bells and are often called alarm symptoms or red flag symptoms are unintentional weight loss, which is not a characteristic of IBS, although sometimes people do have some weight loss for other reasons. Rectal bleeding. Again, rectal bleeding is not a feature of irritable bowel syndrome, and whilst it is relatively common and often has a benign cause, it is not a feature of IBS. And in those people who have rectal bleeding, we should consider further investigation because it can be a reflection of more sinister disease. Patients who have a personal or a family history of gastrointestinal or ovarian malignancy should also be considered for further investigation. Similarly, in people approaching maturity, usually considered to be those over 60, who have a relatively short history, perhaps less than 6 months, certainly those with a story of less than 6 weeks, we consider further investigation because clearly their risk of more worrisome conditions may be higher. So, in terms of red flags, we need to make sure that patients don't have any of those features, and where they do, we need to consider further investigations. We're doctors, so we examine patients, and people with irritable bowel syndrome should have a normal abdominal examination. That means that they shouldn't have any abdominal masses or lumps or bumps that you wouldn't expect to feel. Similarly, they should have a rectal examination. It's not very nice, it's not very comfortable, but it should be normal. And lastly, we wouldn't expect to see any signs of anemia. Anemia is not a feature of irritable bowel syndrome. It's quite common, and there are lots of causes, but it's not a feature of IBS. So, there are some diagnostic tests that we need to do to make the diagnosis of irritable bowel syndrome certain. Those are certainly a full blood count. Now that's a blood test which looks at whether people are anemic and looks at the white cells and the platelets within the blood. And there are two components which may be elevated or deranged if people are unwell from other conditions, but one would expect to be normal in IBS. Similarly, patients should all have either an ESR or a CRP, an erythrocyte sedimentation rate, ESR, or a C-reactive protein, CRP. Again, those are markers of inflammation in the blood, and they should be normal in patients with irritable bowel syndrome. And then all patients should have celiac serology done, and that should be negative. Celiac serology is a test, often a series of tests in fact, for antibodies to a protein that is contained within wheat, a common ingredient in many of our recipes. It's important that that diagnosis is made because it has very specific treatment, and by giving those specific treatments, which are usually dietary, patients can avoid some of the potential complications of celiac disease. The test is important in patients who present with symptoms which would fit irritable bowel syndrome, because the symptoms of celiac disease can mimic those of irritable bowel. So those are the tests we need. But I'm often asked, shouldn't I have other investigations, such as an ultrasound? Now, people who have a story of right upper quadrant pain and perhaps discomfort after eating associated with some belching and some nausea may well benefit from an ultrasound. But if people have the typical story of greater than 6 months of abdominal discomfort associated with altered bowel habit and bloating, in that context, with normal investigations and examination, we wouldn't normally undertake an ultrasound, and it wouldn't generally help us to make the diagnosis of IBS, unless of course there were other features. Similarly, CT and colonoscopy is sometimes considered for those with other features, for example rectal bleeding or weight loss, but shouldn't really be necessary in those who have a characteristic history of IBS. We sometimes use, in our institution, some fecal tests, such as fecal calprotectin, and they can be useful in excluding other diseases as well, because they're slightly more specific than the blood tests. Blood tests tend to measure what's going on in the entirety of the body, whereas clearly, because stools come from the bowel, they more closely represent what's going on in the bowel. So sometimes we would consider a test called a fecal calprotectin, although that is not available in all institutions. Similarly, I sometimes do pancreatic function tests in patients if they have loose stools and they either struggle to gain weight or they've lost some weight. Again, the loss of weight is an alarm feature which may well provoke, and certainly should provoke, the consideration of further investigation. So, in summary, if patients have characteristic stories with 6 months of abdominal pain and discomfort, bloating and altered bowel habit, they have normal examinations and no alarm features, with a normal series of full blood count and CRP and celiac serology, that is sufficient to make a definitive diagnosis of irritable bowel syndrome. I'll perhaps talk on another occasion about the genesis of IBS and what its causes may be, and the available treatments. Thanks for listening.